Hello, my name is Alexis Durham. This is my infant assessment video. So first I'm going to gather all my equipment. I have my makeshift tape measure. I have my stethoscope. I have my thermometer. I have either a watch or a clock with a second hand. My pen light. And then you would also have an otoscope and an ophthalmoscope. So before we begin, of course, you're going to want to wash your hands, and then throughout the exam, remember to keep the parent engaged if possible. Their help can be very useful as far as holding the infant or calming them. And then keep in mind that unlike the adult assessment, when you are doing a physical assessment on an infant, it's not necessarily head to toe. For example, if the infant is not crying, you're going to want to listen to the heart and lungs first so that you can get a clear idea of heart and lung sounds. And then always remember with any pediatric assessment, you're going to want to do the least invasive assessments last. So first things first, when an infant is first born, the very first assessment that is done for them is the APGAR. It's done at 1 and 5 minutes. There are 5 categories. The first one is activity. They get a 0 score for absent movement, a 1 for limited movement, and 2 for active movement. The next one is pulse. They get a 0 for absent pulse. They get a 1 for heart rate less than 100 and a 2 for a heart rate over 100. The next is grimace or irritability. They get a score of 0 if they're flaccid and a 2 for good active motion. Next you have appearance. They get a 0 if they are blue or pale and a 2 if they are completely pink. They would get a score of 1 if they had a little bit of circumoral cyanosis or something like that. And then the last one is respirations. They get a 0 if there's no respirations, a 1 for a weak cry, and 2 for a vigorous cry. A score of 7 to 10 at the 1 or 5 minute mark indicates a well-adapted infant. And then if you have a score of less than 7 at the 5 minute mark, you're going to continue to assess every 5 minutes until either the score goes up, the infant is intubated, or until they are transferred to the NICU. Next, you are going to assess the infant's reflexes. The first one is the rooting reflex. So with holding the infant to assess the rooting reflex, you are going to gently stroke one side of the infant's face, and the infant's head should turn towards the side that you stimulated, and that should disappear at about 3 to 4 months. Next is the moral reflex. You're going to have the infant in a sit position. You're going to support the head and chest, and then you're going to let the infant fall a couple of inches. The arms and legs should all extend, and then the arms should return midline in a C shape, and any asymmetry in the flexion or extension of the arms or legs, specifically the arms, could indicate a brachial plexus injury, and that'll disappear at 4 to 6 months. Next is the gallant reflex. You're going to place the infant in ventral suspension, and then you are going to stroke down one side of the infant's spine, and the infant's hips should turn in the direction of the side of the spine that you stroked. That should disappear at about 4 to 6 weeks. Next is the sucking reflex. You're going to place one gloved finger inside the infant's mouth, and the infant should vigorously suck. Next is the tonic neck reflex. You're going to lay the infant supine on the examination table. You're going to turn the infant's head towards one way, and then the arm and leg on the same side which the head is facing should be extended, and then the arms and legs on the contralateral side should be flexed. You're going to repeat that on the other side, and that reflex should disappear at about 6 months. Next, you have the palmar grasp reflex. You're going to place your finger on the infant's palm, and the infant should firmly grasp your finger. That should disappear at about 3 months. The stepping reflex, you're going to support the infant under the arms and let his feet touch a flat surface, and you're going to see the legs flex and extend in a walking pattern. That reflex should disappear at about 4 to 8 weeks. Next, you have the Babinski reflex. You're going to take the bottom of the infant's foot and stroke from the heel to the toes. You're going to see the toes hyperextend and fan out, and that reflex should disappear at about 2 years of age. If you're seeing any absence in these reflexes or persistence longer than after they should have disappeared, that can indicate a brain or spinal injury. Well, after the APGAR assessment has been performed, on a more continuing basis, you're going to be doing physical assessments. First, with the general survey, you're going to be assessing muscle tone, symmetry, respiratory effort, alertness of the infant, and the interaction with the parent. You're also at this time looking for any signs of abuse or neglect, such as poor hygiene, inappropriate dress if it's cold outside and the infant doesn't have a jacket, or any physical signs such as burning or bruising. As far as vital signs, for a temperature, an infant, you always are going to want to take an axillary temperature, and the range is the same as that as an adult, so 97.7 to 98.6. For pulse and respirations, you're going to listen for a full minute. Apical pulse should be 110 to 160 beats per minute, and respirations should be between 30 and 60. Blood pressure is not normally used for infants, but if they are taken, the systolic blood pressure should be between 50 and 70. Assessing for pain, you're looking for excessive irritability, and the parent may be able to help you if they notice that the cry is out of the norm for their infant. As far as measurements, you're going to take their weight, you're going to zero the scale, lay a blanket over the scale to keep the infant from getting cold, and then while they're on the scale, you can go ahead and do your measurements. You're going to measure with your measuring tape from the crown to the heel, then also around the chest and around the head. At its largest point around the head and chest. Next, you're going to assess for nutrition. You're really looking at the hair, skin, and nails. The hair should be shiny and soft. The skin should be soft and supple. The infant should be saturating 4 to 6 wet diapers a day, or having about 2 bowel movements. That's a good way to assess if the infant is breastfeeding. If they're formula feeding, they should be getting about 100 calories per kilogram per day, and you can calculate that using the label on the back of the formula container. The infant should have no signs of dehydration, so their skin should not be dry. They shouldn't have dry membranes. The fontanelle should be flat, not sunken. And their growth should be progressing in a forward manner. They should not be regressing, losing weight, or not reaching those milestones. Next, the mental status. You're looking for inconsolability, excessive irritability, or inability to arouse. Those are all abnormal. Next, you're going to assess the skin. The skin should be free of any rashes, bruising, or edema. It should be supple and have good turgor. Some normal skin alterations you might see are a Mongolian spot, which is a bluish area on the lower back or the buttocks. You see that with infants of Hispanic descent. You could see what's called a macular stain, which is a capillary malformation. You can see those on the eyelids or between the eyes, or possibly on the nape of the neck. They're commonly referred to as stork bites. They generally fade by 1 to 2 years. You could see a spider nevus, which is a benign lesion with branching vessels coming from the center, and it'll blanch with pressure. That's also normal. One abnormal finding that you could see is jaundice, which is due to the infant's immature liver and its inability to clear bilirubin from the bloodstream, and that is toxic to the infant's brain. That needs to be referred to the physician. Next, you're going to assess the head and neck. You're looking for size, shape, and symmetry. You're looking at the posterior fontanelle, which is going to be at the back of the infant's head. That should be closed by about 3 months, and then the anterior fontanelle should be closed between 9 and 18 months. Those should be flat. If they're bulging, that could indicate increased pressure. And if they're sunken, that could indicate dehydration. The sutures, you should be able to feel them clearly. You're assessing to make sure that they're not closed prematurely. For facial symmetry, you're looking for Bell's palsy and making sure that the neck has full range of motion. If it does not, that could indicate meningeal irritation. The infant should be able to hold his head up by the age of 4 months, and you're going to go ahead and auscultate over the infant's clavicles. You're listening for crepitus that could indicate a birth trauma. Next, you're going to assess the eyes. You're looking for asymmetry in slanting or spacing, and that could indicate a fetal alcohol syndrome or chromosomal defect. You're looking to make sure that the pupils are equal and reactive. You're going to do that by shining the light and making sure that they react and they accommodate. Next, you're going to elicit the red reflex. You're going to do that using your ophthalmoscope. You're going to basically shine a light in the infant's eyes from about 15 to 26 inches, and you should see a red color reflecting. If you cannot elicit the red reflex, that indicates a cataract or neuroblastoma. That needs to be, the physician needs to be notified of that also. And it's normal for the infant to be sensitive to light and have limited range of vision for about the first 3 months. So next you're going to assess the ears. You're looking for symmetry. The pinna should form an invisible line with the inner and outer canthus of the eye. You're going to visualize the tympanic membrane using your pneumatic otoscope, and you're looking for otitis media and also patency of the membrane. So you're going to have the parent place the child in their lap and gently restrain the arms while you take your going to take the pinna and pull it up and back so that you can have direct visualization of the membrane. You're going to position your otoscope about 1/4 inch inside the ear canal and make sure that you stabilize it in case the infant moves. You don't cause any damage to the structures. And then you are going to assess for patency, and you're also looking for inflammation, indicating otitis media. You're then going to take the pneumatic otoscope and gently puff some air, and you should see some movement of the membrane. Next, you're going to assess the nose, mouth, and throat. You're looking for the nose to be midline and symmetrical. The nares should be patent, and you can do that by taking a piece of chilled glass and placing it under the infant's nose and looking for the condensation on the glass. You shouldn't have any nasal flaring. That's indicative of respiratory distress. The throat assessment usually should be deferred until later, but if the infant is crying, you can go ahead and do that assessment. You're looking for a deviated uvula or any obvious signs of a cleft palate or lip. The mucous membrane should be pink. And you want to make sure that there is no asymmetry of the nasal folds or of the nasal bridge. Also, that can be indicative of fetal alcohol syndrome or a chromosomal abnormality. Next, you're going to do the thorax and the lungs. You're looking for symmetry. There should be no retractions, there should be no accessory muscle use or any other signs of respiratory distress. You're going to go ahead and auscultate all the regions of the lung sounds, front, side, and back, and they should be clear. You should see brisk capillary refill of the extremities and also absence of cyanosis. However, if there is some circumoral cyanosis while the infant is crying, that can be normal, but there should be no central cyanosis. Next, you're going to assess the vascular system. You're going to auscultate at the PMI and also over the neck veins. You're listening for murmurs and bruits. Some murmurs can be harmless and go away as the infant grows older. You're also going to assess the peripheral pulses. You're looking for brachial, radial, and also pedal pulses, making sure that they match the apical rate of the heartbeat, and also looking for strength of the pulse and making sure that they're the same from the upper extremity to the lower extremity. If there are diminished lower extremity pulses, that can indicate a coarctation of the aorta or another heart defect. Next, you are going to assess the infant's abdomen. You're expecting it for its size and shape. Also, it should be symmetrical. The abdomen should be soft and it should be round. You should see the abdomen rising in synchrony with the diaphragm, and you should see no visible herniations. You're going to auscultate in all 4 quadrants for present bowel sounds and also to rule out obstruction. Next, you're going to percuss all regions of the abdomen. It should be resonant over the bowel, and it should be dull over in the right upper quadrant over the region of the liver, and also over the symphysis pubis if the bladder is distended. Next, you're going to palpate the abdomen to rule out any umbilical or inguinal hernias, and also for any organomegaly, or if the abdomen is found to be hard, that could indicate an obstruction. Next, you're going to assess the musculoskeletal system. You're looking for symmetry of movement on both sides of the body. And also you should be palpating all the major joints for any crepitus. You are going to make sure that the ankles have full range of motion and that the feet return to neutral position midline on their own. You are going to perform Ortolani's maneuver, in which you are going to lay the infant supine flat on the examination table. You are going to have their knees and hips flexed at 90 degrees. You're going to have your middle fingers on the great trochanters and your thumbs on the inner thigh, and you are going to gently abduct the hips while applying upward pressure, and you should be hearing no clicking. Then to do Barlow's maneuver, you're going to hold that position and then apply downward pressure while adducting the hips, and you should see that the head of the femur remains in the acetabulum. Next, you're going to assess the neurological system, which a lot of your other assessments are indicative of the neurological status of the infant. Basically, you're looking for obvious signs of head or spinal abnormalities visually. You're looking for different abnormal signs and symptoms such as persistence or absence of normal reflexes, any involuntary movements. You're looking for an absence of the blink reflex or any abnormal posturing. Next, you're going to inspect the genitalia for a female. You're going to visually inspect the vaginal opening. It should be present, it should be not have any drainage, and there should be no odor. You can go ahead and let the parents know that if they see any light spotting in the diaper, that could be normal, and that it's also normal for the labia to be enlarged for the female. For the male, you're basically making sure that the urethra is midline, and that the testes are fully distended and that there's no lesions or edema. Next, you're going to assess the anus and the rectum, which is not routinely done unless there are issues, but basically you're just looking for it to be well formed and that there's no redness or bleeding. And that is the end of the infant assessment.